Hey everyone, it's Mikki here. You're listening to Wikipedia, and this week on the podcast I speak to Dr Glen Davies. He is one of New Zealand's most vocal champions, reversing type 2 diabetes through therapeutic carbohydrate reduction. From rural general practice to a mission hospital in Papua New Guinea, Glen's clinical journey has been anything but conventional. But it was discovering the power of low-carb and fasting, and we talk about how that happened, that made him feel like a healer again. Since then, he's helped over 150 patients in Taupō put type 2 diabetes into remission, an achievement that's not only reshaped his practice, but challenged the conventional approach to chronic disease management. Glen was named General Practitioner of the Year in 2021 and has just gone on to be involved in and lead research to help other GPs along the way and assist them in being able to do the same. In this conversation, we explore what remission really means in clinical terms, the systems that help sustain it, and the biomarkers that shift most consistently with a therapeutic carbohydrate approach. Glen also shares insights on the psychology of behaviour change, the risks and rewards of keto, and the real-world barriers to scaling this model across New Zealand. We have a frank conversation of the level of knowledge that GPs have to prevent and treat the modern-day health crisis that New Zealand, like most countries, is facing, and how what they learned in medical school is just so vastly different from the challenges that we have now. And we spend a good deal of time talking about this. Super interesting. For those of you unfamiliar with Glen, he graduated from University of Otago in 1989, worked in a mission hospital in Papua New Guinea for 2 years, and over time went into rural general practice. And it wasn't until he went to a conference and heard Professor Grant Schofield speak that the penny dropped in terms of low-carb, healthy fat, ketogenic diets and fasting. He runs the Reversal New Zealand Return to Health Clinic in Taupō and links clinicians and coaches together in a way that allows for sustainable behavioural change. And I have got links as to where you can find Glen and the Reversal NZ program in the show notes. Before we crack on into the interview, I'd like to remind you that the best way to support this podcast is to hit the subscribe button on your favourite podcast listening platform. And that increases the visibility of Wikipedia in amongst literally thousands of other podcasts out there. So more people get to learn from the experts that I have on the show, such as Dr Glen Davies. All right, guys, enjoy this conversation. Dr. Glen Davies, thank you so much for taking the time to talk to me. And I actually feel it's a bit remiss on my part that it's taken me this long to reach out for a podcast, because I've been meaning to for years. And I mean, you are so well regarded with good reason in this, not internationally in the type 2 diabetes space, and of course in New Zealand. And I'm just really thrilled to have this opportunity to chat to you about it.
Oh, well, thank you so much for the invitation. And yeah, we should have spent a lot more time together through the years, shouldn't we?
Yes, I know, right? But I mean, you've had quite a long history, I think. How long have you been how long have you been a doctor for, actually, Glen?
So if you can do the maths, 1989 was when I graduated. So I should know what I'm doing by now, eh?
Well, yes. And as other doctors in the same boat should also know that. And you've really practiced, like, it feels like your career has been very varied, I suppose, over the years, from rural New Zealand to like a mission hospital in Papua New Guinea. So I imagine that in your sort of background, like you've obviously seen a lot. But of course, I'm interested to know what sort of drew you to metabolic health, or did metabolic health find you? Like, what's the deal?
Yeah, well, it's interesting thinking about that, because 1989 is probably towards the end of that period of time where we didn't really have much chronic health problems, or really a lot of metabolic issues. Probably started in the 1980s, didn't it? And New Zealand was a bit behind the United States. So I probably started my career when these illnesses were becoming more prominent. And through my career, we've got to this point now where they're at epidemic proportions. And I was thinking about it, it's a bit like boiling the frog, isn't it? It's grown with me during my career. And so you don't really notice something that's happening so slowly like that. So that was just sort of an interesting observation I had this morning. I've grown up with chronic disease. Yeah, but your question, what drew me to it? So one event that happened was a patient of mine, Wayne, he came into my room between clients and he told me that I was, not using a swear word on your podcast, useless with the swear word before it. And he suggested that I should occasionally do some reading, which was a good suggestion. And he dumped 6 books on my desk. So one of them was What the Fat by Professor Grant Schofield and Karen Zinn. And the other one was Jason Fung's book, The Diabetes Code. The Diabetes Code. So he's also done the Obesity Code, both brilliant books. And those 2 books had a profound impact on me. And then very close to that time, I heard Grant Schofield lecture at the GP conference in Rotorua. And he suggested this entirely new concept to me that diabetes could be reversed. It was the first time that I had even heard that idea suggested. We're talking type 2 diabetes, of course. And it was profound. But the thing that really impacted was the lecture I went to immediately afterwards was from a bariatric surgeon who said diabetes can be reversed. And so I heard these in 2 consecutive lectures, a concept which was brand new and I'd never heard before. And I went, I've got to find out more about it. And so those 3 events, I think, was what changed something for me. And, when I think about it, I was completely brought up in this infectious disease model or the germ theory. That was just what I was taught. That was everything that I was taught. And the pharmaceutical model, a pill for every ill, that's just what I grew up in. And then I started getting this discontent, and I started asking my mentor, as a GP, what do we actually do? And do we actually achieve anything? That was, I guess, the start of questioning period. And then this challenge that came from Grant, the bariatric surgeon, my patient Wayne, and then this period of I actually don't achieve anything substantial in my day. Like I have good fun. I have all these conversations with people, but do I actually truly make a difference? The realization, no, actually I'm not doing anything substantial. And that birthed this whole journey of we've got to do things differently. The model has to change. We have to have some new understandings, some new tools, and a whole new approach to this new spectrum of disease that didn't exist before 1980. And we're still using these models which are no longer fit for purpose. So, we need a whole revamp of the entire system. And I think these concepts of insulin resistance and carbohydrate restriction are really the keys to redesigning our health system.
Yeah, super interesting, Glen, hearing you reflect on your practice as a GP. Like, I often wonder, I wonder, like, how many clients or patients go into their doctor's office with resources like that might just be dismissed by the person that they're giving it to. So it takes a certain type of person to not be too offended to have that interaction with their patient, but then actually look to look further and explore. Like, not everyone, I think, would do that. And I know this from the clients that go in that I have to their GPs who are absolutely dismissed out the gates on any ideas that they bring to the table. Like, it's just not even a conversation. Obviously, that's not all GPs, and hopefully, I'm not suggesting that. But like the majority of patients that you might have seen, because I always wonder, how do GPs keep all of this information in their head to see all of the variety of people with their problems?
Well, we don't, Mikki. We've got ChatGPT now.
Oh, thank gosh. I know. It is a whole lot easier. I totally agree. But were the majority of people you were seeing, were they actually presenting to you with similar problems, like with metabolic health related issues?
Yeah, well, it's changed, like I was alluding to before. We virtually only saw infectious diseases and injuries, didn't we? And that's quick and easily fits into this 15-minute or 10-minute consult, or back in the UK, 12.5-minute consult, or or 6-minute consult, but it fits into that. Now you're dealing with these complex chronic conditions that you can't manage in those short period of time, and they need a whole new approach. Just back to your comment, Wayne has an IQ of about 160, so I think that's why I actually listened. I really listened to him. I went,
Yeah.
it's pretty hard to formulate a strong argument with someone with an IQ of 160. I better actually do as he says.
Yeah, I really like that. That's nice. Hey, I don't know if you'll remember, but I'm interested to know what the vibe in the room was when you sort of heard Grant say it's reversible type 2, because you've gone down quite a different path to a lot of your colleagues, clearly. And, you might not recall, but was there a potential sort of feeling in the room of, oh yeah, this guy's onto something, or no?
No, I think he was just viewed as a bit out the gate. So no, I think I might have been the only one that went up and spoke to him at the end of the lecture. So no, I think it didn't impact. But I think we're talking around 2016. And if you think about, What the Fat, for example, it was one of the earliest books, and Grant and Karen have been talking about this when people didn't even understand what a carbohydrate was, I think. Now when you're having this conversation with people, virtually everyone will say, oh, my daughter has done keto, or my uncle's on a low-carb diet, or I've been following someone online. You're no longer having to introduce the idea. So the other thing that happens is GPs have been brought up in this pharmaceutical model and this germ theory model. Anything which contradicts that is considered to be unworthy, isn't it? So nutrition is not really considered powerful. Supplements are not considered powerful. Herbal medicines are disregarded unless it's backed by pharmaceutical studies and part of guidelines. It's largely dismissed by standard medicine, but I would challenge that, because what we're doing is not working. So we need to really be looking at a whole new approach. And I like the idea, starting with the idea, I know nothing about this topic. That really encourages you to learn. When you go, I already know everything about this, there's nothing more to learn. You're not a lifelong learner in that situation. So I think one of the issues with the GP sitting in the room, they were going, well, I already know everything about diabetes, and it's in the guidelines, and what Grant's talking about is not in the guidelines, so it must be wrong.
Yeah, no, 100%. And to that point, like for many years, because I went through the university system with my nutrition degree and then my postgraduate work, etc., like it almost makes you more arrogant, and your blinkers are on even tighter, because you're like, I went through the ivory tower. Like, this is where you learn knowledge. Like, don't talk to me about herbals, or my practice husband's brother, actually, he was into Mark's Sisson and Mark's Daily Apple and Primal and Paleo well before I'd heard about it. And he was telling me about it. I'm like, oh, well, that's obviously rubbish, and you just get so arrogant when you are, I think, in the system that is the holder of knowledge or the holder of truth. And it's not until and I think that's harder barriers to break than sort of people who haven't had that background, right?
So how do you create a lifelong non-learner? Tell them that they're the brightest cohort that left school, and you've given them the best possible education they can have. You've created a lifelong non-learner. tell them that they're not actually that clever, and the stuff that we're teaching you, we don't actually know if it's right or wrong. You've created a lifelong learner. And so I think that's one of the biggest issues with medical graduates. They're not incentivized to learn.
Yeah, such a good point. We've talked about type 2 diabetes, like reversal, obviously. And you said that discovering low carb and fasting made you feel like a healer again. I've seen that written. Now, so one, my question is like, when you found this information, did you start practicing it yourself? So first, like how did it change your own diet practices?
Yeah, good question. Yes, it did, and I'm sure all of us in this area have played with all of it, haven't we? You know, we've played with fasting, and we've played with intermittent fasting. We've played with strict keto because that's really fun, isn't it? And to be checking your ketones, and we've worn continuous glucose monitors. Yeah, because I don't have any chronic health issues myself, I've ended up in a low carb paleo sort of space. But yeah, I've definitely played with it. And one of the most fascinating parts of wearing a continuous glucose monitor was seeing I don't have diabetes, but seeing my blood sugars go up close to 7, just getting out of bed in the morning to feed the chickens. That was an astounding fact.
Yeah. And in fact, I was speaking to a client this morning about, because she occasionally wears a CGM, and she was concerned about the blood sugar spikes from her cardiovascular exercise and from the sauna and from the cold plunge. And I'm interested, like, I think you and I are on the same page with CGMs. I think they're so valuable for people for understanding food and stress and sleep restriction. But of course, there's a lot of pushback from people who think that if you don't have type 2 diabetes or, of course, type 1 diabetes, then the CGMs are not, they shouldn't be an option for you. Like, you're actually just creating this sort of orthorexic thinking. And I don't agree with that premise. Like, I think that with everyone and with what we know of metabolic health in the community, just because you don't have a diagnosis does not mean that you don't have to care about your blood sugar.
I love what you just brought up there, like this idea that everything's fine until you have diabetes. And Grant Schofield uses this term. He says that pre-diabetes is pre-nothing. It's like we've got to recognize insulin resistance and recognize that insulin resistance is a problem. I think we should get rid of this whole name type 2 diabetes. I think we need to rename it. I'm happy to do that with you right now. But, we need to be calling it insulin resistance. We need to be calling it compromised insulin resistance, and we need to be calling it something like uncompensated insulin resistance. And we need to be recognizing insulin resistance, whether that's ordering a C-peptide and a fasting insulin or using some other method. But we need to diagnose that. We need to be putting that as a classification in people's notes, and that's when we need to be intervening. As soon as you have a rise in your HbA1c, as you know, you've decompensated. The body is no longer coping. That is a significant, real problem, and it breaks my heart to see GPs seeing an HbA1c of 41 or 42 and filing it and not even necessarily telling the client or the patient that that's a problem. And then they come back in 6 months' time and have it repeated, and it's gone into the diabetic range, and they say, great, now there's something we can do. We can start you on some medicines. That whole process has to change. And I would, if we diagnosed insulin resistance, that whole thing would change.
No, I love the way that you think about that, Glen, because even another client this morning and I were talking about her history with her A1C, and she'd gone from 43 to 50, from 43 to 50 down to 39, and she got herself a CGM and was able to do it. She just said that her HbA1c was in the pre-diabetic, quotes, range for years. GP never did anything about it. And so she didn't realize that it was an issue until it was 50, because that's when she found out about it. And I'm not sure where this sort of concept of like that it's like it's such an arbitrary number, isn't it? That 41, like, and things just, in that 39 you're sweet, and at 40 you're fine, and 41 there's an issue, and then we'll file it under pre-diabetes.
Now, so the problem is that the pharmaceutical model says unless there's a medicine for it, there's nothing we can do. GPs don't recognise the power of carbohydrate restricted nutrition and lifestyle change. So they're basically just waiting until it hits 50. Then they know what to do, because then they have tools. Up to then, they don't have tools. Well, they do, but they don't recognise that they have tools. The population knows, and many people in the community know, but medicine hasn't recognised that we can make lifestyle changes, from before the blood glucose starts to rise, and that's what we need to change. And this term pre-diabetes has to disappear from our language, because the I'm fine, nothing's a problem, I've got let's call it insulin resistance, compensated insulin resistance, and decompensated insulin resistance, or organ failure. It's a form of organ failure once you've got diabetes. You have got so metabolically unwell that your body isn't compensating at all. It's a big problem. And calling it pre, it's like, oh, okay, nothing I have to do. It's a terminology that has to change.
Yeah. And you mentioned C-peptide. Is that something that a GP can order? Because I've heard other doctors say fasting insulin it's not as helpful as what it could be, because, it's pretty labile to change.
Yeah. So C-peptide's my preferred test. So if people don't know, every time you make an insulin, it's linked to a C-peptide. There's a one-to-one relationship. Insulin's a very volatile molecule. C-peptide's much more stable. Its only function in the body is to hang around for us to measure. That's not true. I'm sure it does other stuff, but it's really hanging around in a much more stable form, and we can use that as, I believe, a really practical way of determining if someone has insulin resistance. Now, many doctors believe they can't order it. I've never had a problem ordering a C-peptide. Clients aren't charged for it. It's a simple blood test. You do it fasting, of course, if you want to know what the fasting level is, and you do it postprandial if you wanted to know what the postprandial impact is. And sometimes you do actually need to know that. We might be getting a bit technical, but sometimes you are left with asking, does this person have type 1 or type 2 diabetes? One of the ways that indicates that is doing a fasting and then a postprandial C-peptide, and I find that a really useful thing to do. The other nice thing about C-peptide is if someone is on insulin, you can measure C-peptide, and you're only measuring the endogenously produced insulin. You're not measuring the injected insulin, because clearly there's no C-peptide associated with what you inject.
Yeah. Okay. And obviously that we're talking in the context again in type 2 diabetes in that instance. Glen, so do you think then it is valuable for people to get fasting insulin and C-peptide measured, and then also the postprandial C-peptide as well? If people feel they want to explore their metabolic health further because they think something's up.
Yeah, well, it really depends on what the client's asking you, but throwing a C-peptide in as part of your annual check, to me, would be the most important test. We do. What do? We do renal function, liver function, full blood count, iron, B12, a prostate, a PSA, and a CRP, don't we? what if we just did none of those and we just did a C-peptide? I think we would be picking up the insulin resistance and doing more for that person's. So if there was one test to do annually, it's got to be the C-peptide.
Do you know if you can get that on mytests.co.nz? I imagine you could actually. Like the website where you can just order your own tests.
Not sure because I'm lucky I can order them, but
true.
Yeah, I'm sure you can.
Yeah. And then are you happy with the parameters that are provided by the laboratories as to what's normal and what's not?
No. So they say something like up to 750 is normal for non-obese people, and then up to 1,440, I think, is normal for obese people. But clearly there's an issue there because the people with obesity also have insulin resistance in many cases, and the two conditions are linked and happening at the same time. So I use 750 as my normal.
Okay. No, that's really helpful because, that's because getting the test is one thing and interpreting it is quite another. And of course, I would always recommend that people get these kind of tests interpreted with the help of a health professional or, a health coach who obviously works in an organization like yours, or a nutrition professional, someone a bit like me and similar. Glen, what do you mean by reversed or in remission with type 2 diabetes? So how do you actually verify that? Is it with the C-peptide?
Yeah, I had to actually look up the definitions this morning. I use the term reversed, and what that means to me is that if someone has reversed their diabetes, their HbA1c is now less than 50, so it's either in the pre-diabetic or the normal range, and they're off all of their medicines apart from metformin. So that's my definition. Looking it up this morning, it said it needs to persist for 3 months. I'm probably a little bit slack on that, but that to me shows they've made significant changes. The term remission, I tend to use them pretty interchangeably, but I'm not sure if you're aware of, is there a distinction between the two? I think there is, but I've forgotten what they are, and I use them interchangeably. I use the term reversed, and then I talk about reversing pre-diabetes. That's if you've gone from the HbA1c of 41 to 49 down to 40 or below. And as you were saying, they're arbitrary, but going along with that, there's a whole lot of other changes that have occurred, but I guess by definition, that's the definition of reversed.
Yeah, no, that's really great. And I think I said this into you in an email that the latest number I had was over 150 Taupō patients have reversed diabetes, but it's got to be more than that now, right? I don't think you've updated your website.
No, I think we're at something like 220.
Yeah.
Now, but just going off track a little bit, if you recall, there was a PricewaterhouseCoopers report saying that by 2040, type 2 diabetes will be costing $3.5 billion per year. I just asked ChatGPT to do a little bit of maths on that for me because I don't have access to a health economist, but it works out that each diabetic is costing $14,000 per year. Okay. Now, if you make a whole lot of assumptions here, but if you assume that if you reverse somebody's diabetes, they go from costing $14,000 per year to zero, which is probably not a fair assumption. But if you did do that, you multiply that 220 by that number, it works out close to $3 million per year saved.
Wow.
Now, I'm not suggesting that was done by a health economist. It's really just to create the concept that this actually is saving potentially a lot of money. If you said that 220 people were pre-diabetic, it's 1.27 million per year, and this is ongoing. So, and that cost $0 to create. This was just one general practitioner with some support from others, and a whole lot of clients that did a whole lot of hard work themselves, that has saved, let's just say, over $1 million per year. Why is the government not looking at that and going, okay, we can spend $0 and save $1 million per year per GP? Why are we not all over this? To me, that's the big question here, and that's the question I'd be like to ask the politicians. This is good economics, ignoring the fact that people improve their health, they become empowered, they feel better, they're less likely to get cancer, they're less likely to have a heart attack, they're less likely to get Alzheimer's. Forgetting all of that, this is good economics. Why is it being absolutely ignored, particularly here in New Zealand?
Who do you need to get in front of to ask that question to, then?
Yeah, I think what we need to do is we need a health economist, not just ChatGPT to do the numbers, and then we need to present that to any politician who will listen, because it's good numbers.
It is, and I appreciate your frustration, because I feel almost resigned to the fact that it wouldn't make a difference who you talk to, because for whatever reason, governments never listen. Like, I'm just thinking about experiences in the past where you make recommendations on things like the guideline, like nutrition, as if they care about nutrition guidelines anyway. I mean, the government doesn't give it a shit, really. They do not care at all about any of this, and it just absolutely blows my mind. Like, prove me wrong. Like, who in today's government actually cares?
Yeah, I would love to be able to sit down with Mr. Winston Peters. I read an article recently where he was talking about his own nutrition.
Yes,
I think he gets it.
Yeah,
I understand he's a very busy man, but I think he might listen. So I'd love an opportunity to even have 5 minutes with you, Mr. Peters, if there was ever a chance.
that'd be amazing. That would be amazing. Anyone who knows good old Winston Peters, tell him to listen to this episode. That'd be amazing. I know I get a little bit, to be honest, I get a little bit angry and raging inside when I think about the government. Any government, actually, not necessarily like this current one or the last one. Okay, so back on track though. What are some of the common denominators amongst the people who are successful? Like, is there a person that you are in a clinic with and you sort of know immediately this is going to click and help them?
Yeah, that's a fascinating question, and I don't know, because I've done as little as send somebody a text saying stop fizzies, and they've reversed their diabetes. That was the entirety of the intervention. An SMS message from the computer when I've seen their HbA1c stop fizzies, and that's all that it took, compared with a complete health coach supported intervention with monthly HbA1cs, and they both work. And I don't know. I think every client, every patient should have the opportunity to make this change. So they need the information, they need the education, and they need to be offered the support. And what causes somebody to run with it, take it up, full on, or make a few changes, I think is very variable, and I don't think I've identified all those factors yet. But I talk to everyone about it. Dr. David Unwin, I'm sure you're familiar with him. He's perhaps one of my greatest heroes. He's a UK general practitioner who almost single-handedly has changed the way that type 2 diabetes is managed in the NHS. So absolute legend, a GP, and all he did was sitting in his office, not doing a whole lot more than that, but largely sitting in his office talking one-to-one to people and offering them the opportunity to talk about their diet. That's largely what he did. And his stats are 50% of the diabetics in his practice have reversed their type 2 diabetes, which is really, really good stats. And I just like the fact that you offer people the choice. And when David Unwin says he offers people the choice between changing their lifestyle or going on a medicine, he says 100% of them choose the lifestyle change. If I went into a room of 100 GPs and I asked them, how many people do you think would choose the lifestyle change over the medicine? I bet you they would say 100% will choose the medicine. The reality in the real world, in David Unwin's world anyway, is it's 100% of people choose the lifestyle change. So there's a huge discrepancy between what the doctors perceive people want and are able to do and what they actually do. So, I think that the majority of people will choose the lifestyle change if they're offered that option rather than medicine. And about 50% of them will achieve full remission of their diabetes, which is pretty cool. And those ones who don't, I'm sure, have also made significant changes and are probably on the way. So that's what has to change. We have to offer everyone the opportunity and the support if they want it. And now, behavioural change is hard. Not everyone is going to take it up at that time, but everyone deserves the opportunity. And that's all I would ask for, that every GP, every health coach, every nurse offers their clients the opportunity to restore their metabolic health.
Yeah, amazing. And for what it's worth, Glen, and I think probably quite a bit, David Unwin spoke very highly of you when I spoke to him about his work as well. So I think you're a bit of a legend in his eyes also. And
Mikki, I said once, sorry to interrupt you, but I said I want to be New Zealand's David Unwin. And when I met with him last year, I said, I'm so disappointed all I've achieved is the same haircut.
That's brilliant.
Yeah.
I mean, you could, doesn't he have a bow tie? You could sort of do that as well. Like that would be
would it go well with my sweatshirt?
Next level. That's true, actually. That is very true. But like to your point about the GPs, I just find that fascinating because this is something which I see a lot, is that in the framework of how, our health system or whatever, like GPs really have such a critical role because they are the people that the general public look to for information, and they are valued higher than the likes of someone like me. Regardless of the fact that I specialize in nutrition, I have clients who will second guess what I've told them because their GP, who knows next to nothing about this, will tell them otherwise. And so I 100% agree with you that something has to change in the way that the GPs are communicating information, and their knowledge is probably going to have a hugely profound effect because that's the grassroots stuff, right? Like we talked about, politicians need to get behind this. Well, I mean, they do, but it's actually the GPs in the room with the people.
Yeah, so let's look at that a little bit. We have a germ theory medical environment. We don't have a host theory environment. That goes back 200 years, doesn't it? Then we have the pharmaceutical industry with a very, very strong influence over medical student training, and then those two things affect the way that doctors think. And we talked about it before, but doctors don't think nutrition is powerful. You and I recognize nutrition as perhaps the most powerful tool we have. It's the chemotherapy of medicine, in my view. A ketogenic diet, for example, is a hugely powerful, strong metabolic change. Doctors haven't been taught it. I think it's 6 hours of training in a medical degree, and most of that was just the biochemistry of B12 and iron. So we're not taught it. How do we introduce it into medical curriculum, into GPs training, and then get GPs to start thinking in terms of host theory rather than germ theory, and then viewing medicines as your plan B, as your second line option, either for the people who aren't ready to change, maybe choose not to, or have tried and they need a little bit of extra assistance. That's the role of medicines. It's not first line, particularly not in type 2 diabetes. And just if I could say this fact, insulin in type 2 diabetes is malpractice.
Oh, interesting. Yeah.
When you understand insulin resistance and hyperinsulinemia, there are very, very few type 2 diabetics where insulin is going to help the problem. It certainly will lower their blood glucose, but that glucose-centric model has got to change to an insulin-centric model. And I would love if we could even get GPs to understand the system, that the cell is packed. This is not type 1 diabetes where the cell is devoid of energy and starving. This is a system which is overfull with fuel. I'm thinking, and I'm sure you can picture the picture too. Jason Fung has that model of the Tokyo Underground with the underground pushers, the men that are pushing people into the train. I printed out the picture, but you and I know the picture, don't you? The train. The train is full of people, and then you've got these men that are pushing people in, and then the platform is full of people. There's just glucose everywhere. This is not a cell which is devoid of glucose. This is a cell that's full. To just push more men there to put more people into the train carriage is not helping the problem. It's compounding it. And that's the issue. Insulin and sulfonylureas, which are increasing the amount of insulin, are compounding the problem, and fixing it is so easy. Stop having fizzies. Do you need those lollies? Could you just have one Tim Tam instead of the whole packet? Sometimes it's really, really simple stuff like that. It's not having to do the full metabolic health education. Sometimes it's simple, but insulin is malpractice in 99 out of 100 people with type 2 diabetes.
Yeah, that's a pretty powerful thing to say, Glen. And I can't imagine, I do wonder, your colleagues listening to this who have done exactly what you've just described, how would they respond to that?
I think I would be probably taken in front of the medical council, but it's a profound misunderstanding of what type 2 diabetes is. Once you understand what type 2 diabetes is, that it's a cell packed full with fuel, and packing more fuel into it is not the solution. In Jason Fung's analogy, half those people that are standing on the platform need to work from home today. Okay, you guys are not getting on this train. You're not going to the office. You guys can work from home. You've solved the problem, haven't you? It's the supply of food which is the problem, and don't sort it by insulin. In this analogy, instead of 2 guys trying to push everyone into the train, let's have 10 solve the problem. You haven't solved the problem. You've compounded the problem.
Yeah, and it's so simple the way that you describe that. Yet I don't know, it's like it really does baffle me that more people aren't aware of it, actually. I'm quite I think it's a little bit.
Well, you've got the companies selling insulin who are compounding this problem, because type 2 diabetes is this huge potential market for them. If you're one of the top executives in an insulin company, you go, type 1 diabetes, absolutely. It's a contained market. Type 2 diabetes is expanding extraordinarily. How can we persuade the medical profession that people with type 2 diabetics require insulin? And we've seen that recently. There were ads supporting the use of insulin in type 2 diabetes recently. Another thing, our PHO pays $155 for us to introduce insulin in a new patient. So we're incentivized for this malpractice. There is no money, not a cent, for reversing somebody's diabetes. So we are incentivizing malpractice, and there is no incentive whatsoever to sit down with someone, and it takes longer. It's much quicker to write a prescription for insulin than to talk to somebody about insulin resistance, metabolic health, diet, and what do you actually eat. Of course that takes longer. That should be what's being funded.
That is super interesting because, of course, people often talk about doctors being swayed by pharmacy and by the people who are selling the drugs, but in fact, it's a systemic thing, sort of inbuilt into our health system.
Yeah, it is. And, the pharmaceutical industries, the people working in there aren't bad people. Probably not even the executives are bad people. They're salespeople seeing an opportunity. The level's one step above that. It's this whole germ theory that goes back 200 years and longer that needs to change.
Yeah, super interesting. Glen, I was going to ask you, so what's the minimum effective dose here? But you literally said it before. Hey, stop drinking fizzies. But like fundamental principles for sort of are you, for your type 2, for your so clients that you work with or patients, is it about therapeutic carbohydrate restriction? Is it like go super low keto? Like what in your mind is sort of like the ideal situation?
Yeah, wonderful question. So my answer is you use the coach approach. You meet the client where they're at. You ask inquisitive questions. You find out about the challenges they're facing, whether those are economic or a big family or no time, and you find out what they can do. So there will be people who go strict keto, buy a continuous glucose monitor, get a CareSense dual, work out glucose to ketone index. Absolutely, there will be people. They're often engineers. But yeah, absolutely, there are people that will do that and get incredible success, but that's not where everyone is. And so often the question is, what's one thing that you could do? And they might say it could be as simple as I'll stop the fizzies, and that's great. And can you come back and see me in a month and let's see where that's going, or it could be I just can't face it at the moment. I've got work pressures, kids pressures, school. I'm not well. I can't do it, and that's absolutely fine. And the answer then might be, well, should we look at a medication in the meantime, and until things are less hectic? It's meeting someone where they're at. However, to answer your question, I love keto. If a ketogenic diet, which is any diet that creates the metabolic changes required to produce ketones, whatever that might be, I think is the ideal solution for type 2 diabetes. And as a doctor, I love people being in ketosis because I know that they're burning fat and I know that they're changing their metabolism. So, yes. Interesting. What's my view on carnivore for type 2 diabetes? Often it's hugely, hugely effective, and people get extraordinary results. But I think it's perhaps for a short period of time, because I do think that the very high protein and gluconeogenesis eventually becomes an impact. And I like to move people back to keto, which is higher in fat and more moderate in protein after a period of time. So, yeah. Go ahead.
Yeah, that makes perfect sense. And I also wonder, I can't recall who I was listening to about this, but I'm mindful of older men particularly having a ton of red meat and the increasing ferritin levels and the potential oxidative stress and cardiovascular disease. Like, do you I mean, I don't know, this is a bit not really into the weeds, but I do think about that with carnivore. Like, I think I'm mindful of that for people who, who might be already at increased risk for cardiovascular. I don't know.
Yeah, it's interesting. The one area in this metabolic health discussion that I don't think we've really got the full understanding. I mean, I don't think we've got the full understanding of all of it. By no means, there's still so much more to learn, but it's in that cardiovascular space that I think we still need a bit more understanding. I'm pretty confident with telling people to eat a whole lot more saturated fat. But I think there's still more understanding in in the LDL cholesterol, the LDL phenotype, some of these genetic abnormalities that probably impact the LP little a. There's a whole lot of stuff there that I think I don't think we can be arrogant in that area. I think we can be pretty arrogant in the metabolic health space and the diabetes space. I think we've got that pretty well sussed. I think we've still got work to do in the ischemic heart disease area.
Yeah, no, completely. And it's always super interesting seeing different studies come out and people debate them online, but just actually learning more about it. And I've signed up to Ben Bickman's insulin metabolic classroom, and I love just learning and engaging in that sort of material. Just things like that just open your. I mean, it's all about learning, really. Being a lifelong learner. To your point.
Yeah, indeed.
Yeah. So, Glen, I'm interested in. I've got quite a few questions here, but I'm looking at the time, and I'm really interested to talk about the whole New Zealand project. Can you give us a little bit of information? I was at a conference last year where Karen was presenting a poster on it seems like quite a large sort of undertaking that might move the needle a little bit in the ways that we're talking about. So can we just talk a little bit about that and just sort of your role and what it is?
Yeah, so this project has been led by now Professor Karen Zinn at AUT University, and it's a 3-year implementation science project looking at low carbohydrate nutrition in type 2 diabetes. The point about implementation science, we're not proving that low carb nutrition treats type 2 diabetes. That's already proven. Just a little sideline, not yet in the New Zealand guidelines, despite it being dramatically proven. So anyone listening to us, why is it not? Why is it in the Canadian, the American, the Australian, the UK, and not the New Zealand? But anyway, so hopefully part of this will be to at least get that to change. But implementation science, how do you move that effective theory into general practices? So year 1 was looking at and reporting on the science that we already have. So that's the work we've done in Taupō, the work at Tūriki Medical Centre that is also outstanding, and also some work in Auckland. So looking at that group and reporting on that both qualitatively and quantitatively. Then stage 2 was getting about 20 general practices involved and looking at what do you have to do to move that program into general practice. And then year 3, which is now, so we're still in year 2, but year 3 was how do you roll that out nationwide and make low carb nutrition the normal way that that type 2 diabetes is managed. So that's what that project is. There was a Health Research Council grant to fund that. And then there's a few little interesting projects that have come out of that. One is called Blue Zone Mango. So Mangakino is the small community where we have a general practice. So could this little community of Mangakino become one of the world's blue zones? Can you use these public health initiatives in a whole community? So that's one of them. And another one is looking at different models of healthcare. So one of the ideas is, can we use capitation funding? So general practices are bulk funded. Could you take some of that capitation and could you get a cohort of people who are improving their metabolic health for a year? Could you put extra resources into that group? And this coincides with prescriptions for long-term conditions are now going to be moved to 12 months rather than having to be repeated every 3 months. So people who just are happy just to carry on taking their statin or their metformin and other diabetes medicines, Jardiance, they just get that prescribed once a year and they get invited again the following year. So that's one of those ideas. So a lot of projects that will come out of that, and we are Karen said we're probably going to be able to report on the quantitative findings in about 2 months' time. So I think that'll be a significant international publication.
That is awesome, Glen. And, a lot of what we've discussed is the system and what might need to change in that. And just over the course of the last 10 years, have you seen a significant shift in how your colleagues approach type 2 diabetes with the changing information?
No, not in the slightest. There has all that's happened is the pharmaceutical medicine's argument has become stronger. It's now, but we've now got better tools. We can use GLP-1 agonists as well as Jardiance. We've got these amazing new medicines that are going to change diabetes, and the reality is, no, they're not. I could be proven wrong, but the approach is wrong. This whole topic of the GLP-1 agonist is really fascinating, but when has a medicine rather than a lifestyle approach made any significant difference to type 2 diabetes, and why do we think this one will be different? I believe this is the false promise of medicine. Medicine has repeatedly given these false promises, and each new medicine comes along with all the hype. This will be the solution. This will be the solution. And when you've watched that through a 30-year career, you're going, no, I just don't believe it will, and I might be proven wrong. And I think if we use these GLP agonists intelligently and they're coupled with lifestyle change, absolutely. But just going in, getting a prescription and leaving again with nothing else, I think it's going to be a recipe for failure, or at least a recipe for needing to use them for the rest of your life.
Yeah, no, 100%. And I guess to your point, that whole lifestyle prescription, that can't occur in a clinic that has GPs with, what did you say, 8 minutes? Was that as long as you've got, basically? I know it's an average, but
15.
15, there you go, 15 minutes, there you go. Yeah.
Luxury.
Yeah, and you've got health coaches in your clinic, right?
Yeah. So you must, I don't think general practices can function without health coaches, because health coaches are the expert in behavioural change. And if they're well trained, they'll also be trained in low-carb nutrition. You combine low-carb nutrition with behavioural change, you've got the recipe for success. If you're just sitting down and prescribing medicines, that's the recipe for just getting what you've always had. A progression of the tsunami of chronic disease, because the medicines are just treating the symptoms, not treating the cause. And that applies to whatever chronic health condition you're talking about, whether that's hypertension, whether that's gout, whether that's Alzheimer's, whether that's cancer, whether that's type 2 diabetes. It's treating the symptoms. We need to be identifying the cause. And public health is all around preventative medicine. We need to be going back even one step and changing the food environment, seeing if we can do something about this ultra-processed food. I don't know what the word is, danger, and changing that. And I think we need the change to occur systemically. So we talked before about at a government level, but I think this change is going to be driven from the bottom up. I think this is going to be the public is going to eventually ask for these changes. And what do they talk about? A groundswell of needing about 15% before you get change. Once we get to 15% and people start demanding access to high quality foods, I think we're going to start to see government listening. 15% is about the point where they say, "Oh, there's votes here. Maybe we should listen."
Okay, and how far away is that, do you think? In your lifetime?
Oh, yeah. Yeah, you asked me that really interesting question. What would success look like by 2030? And I thought, yeah, that was I think yes, in my lifetime, I think we will see these changes. But by 30, I would I would love to see this idea of active enrolment introduced into general practices, where people come for a year into a lifestyle medicine program run within general practice. Within the next 4.5 years, I'd like to see that established, based around low-carb nutrition and behavioural change. I'd love to see, I think we will see within the next 4.5 years, the guidelines change so that low carbohydrate nutrition is at least acknowledged as a tool. I would love to see a diabetic diet in hospitals. I don't know how many people you've spoken to recently who say the diabetic diet is still jelly and ice cream. You just get a smaller serving.
It's seriously horrendous. I cannot believe what they are continuing to. I get pictures all of the time, Glenn, in my DMs, and I've stopped posting them because people take my criticism of it as a criticism for nurses and doctors, and I'm like, no. This is the system, but it is horrendous.
Yeah. I'd love to see a public health campaign identifying the dangers of ultra-processed food and identifying ultra-processed food as the cause of the problem. Then is there some way of making the ultra-processed food not the most available choice and making high-quality proteins and vegetables the available choice, and that might take some government intervention to do that. To me, it would be quite simple. You put a tax on the ultra-processed food or the companies making it, and then that money is transferred directly to reduce the cost of either the production and manufacture or the sale of the high-quality proteins, the healthy fats, and the vegetables. To me, I don't think that's going to happen in the next 4.5 years. I think that might take 10. So I see that last part happening in the next 10 years, because the ultra-processed food industry is very, very powerful, and we're noticing all the advertising that, the tobacco companies used to use. We're now seeing exactly the same strategies being applied to food, aren't we? And who used to sponsor cricket? Who sponsors cricket now? So Benson and Hedges used to sponsor cricket, and now it's KFC. We're just seeing a transfer from one toxic substance to another. Just using that as an example of food that's not cooked at home.
Yeah, and I wholly in agreement with all of that. And it's interesting. I was just speaking to someone else earlier about how in the social media space, which is the place that people get their information from, like people in my industry are diluting the messages around food and are softening the edges, saying things like there are no good or bad foods and absolute BS like that. That is not helping the situation, because I think people actually need to understand the true impact of these foods and not just sort of sugarcoat it like, oh, it's all right, you can have just a little bit, everything in moderation. That's BS. That's not on.
It's fascinating. That's a whole other topic. But we've talked about this a lot at Whole NZ. Do we use the term low carb nutrition, or do you talk about ketogenic diets? And the ketogenic diet has become a dirty term to some extent, and so we're using the term low carb nutrition. But are we doing what you've just mentioned? Are we just diluting the messaging? Because a ketogenic diet is a powerful tool.
Yeah.
Hey, Nikki, I've done quite a few podcasts, and one thing I notice is that you as the interviewer never get asked any questions. You are an absolute legend and expert in this area. What would be your sort of summary statements on the state of the management of type 2 diabetes?
That's such a good question, Glenn, and I don't feel like in my professional integrity that I could I don't understand actually from a professional integrity perspective how low carb nutrition, how the powerful sort of nutrition therapy potential of something like a ketogenic diet is just not on the table in those, I suppose, those big organizations that make those decisions around the guidelines and things like that. Like the constant beatdown of people who advocate for low carb nutrition is just mind-blowing to me, actually. And I know over the years that Karen has has come up against it. I absolutely know that Grant has come up against it. And I've never been in a position where people bothered with me, but I always was there to sort of see it. And it's just bloody mind-boggling to me. And the GP thing is just, again, blows my mind that they can really have so much power in this because they're the voice of authority for like generations of New Zealanders, yet they're not in a position, or they don't choose to acknowledge how powerful nutrition could be as a therapy. And I think to my point earlier about how the information that I share with clients is very often dismissed because what would I know, because I'm just a nutritionist, which is just mind-blowing to me as well, that's the attitude. I actually feel a little bit like, I think you're probably more hopeful than I am of change, which is great because you're the one in it doing the change, so you know a whole lot more about that than me. But this is just coming from what I see sort of in the trenches, I guess.
Yeah, I think what's changing is the going back 10 years, you had to tell someone what we were talking about. Now everyone knows what we're talking about. We just got to do the behavioural or the persuasion part, and give the resources. That's what's changed. I think that's a really significant change, and I that's why I'm hopeful, because the public get it, the public know about it, and this will be a bottom up change, I believe. And probably the same thing will keep happening. If you're a GP and you keep seeing person after person after person coming in who's lowered their HbA1c, at some point you must go, well, that's really interesting. What have you done? Rather than dismissing it, or it won't last, or you've probably raised your cholesterol and put yourself at a heart risk. Maybe you should stop. Maybe you should check your lipids because you've probably put yourself at risk. And I see that often. I see people being told to stop doing their low carb diet because the saturated fat will kill them. And of course, as you and I know, that's BS.
Yeah. Do you know the other thing, Glen, is you mentioned it, and this is a message that has to change as well, is the idea that it is hard, because that is what is sold by almost, oh no, like people don't stick to a ketogenic diet, so why would we bother advocating for that? It's too hard for them. So if people have this narrative in their head that, oh, it's just going to be too hard for me, so why would I bother? Why would you?
You've really, really nailed something there. It's like GPs say to me over and over again, I have been telling people for the last 50 years to change and not a single one has. And I said, you hit the nail on the head. You've been telling them. When has that ever worked? And what health coaching has introduced to us is this idea of behavioural change is not part of that paternalistic model and we tell people to do. It's the exact opposite. And that's the reason that GPs have become so disillusioned with behavioural change. Even understanding motivational interviewing, which is taught, they have not seen success, and therefore they believe that people are unable to change. Whereas you and I know that it's the exact opposite. It's just that it has to be done in a different way. And that's what health coaching and, call out for Precure that trains, really good health coaches, that's what's changing, and getting those health coaches trained in behavioural change in your practice so that you don't have to tell people what to do. You just take them next door to the health coach and let them look after that.
100%, Glen. Well, I mean, I know I asked you maybe a third of the questions on my script, but I've really enjoyed this conversation. I love thinking big picture, and I've really admired the work that you're doing, and I love that you are optimistic because you're in there doing it and making the change, which is fabulous. I know that people can work with you and your clinic. Like, how can they find more about either how do people find GPs like you and clinics like you so they can actually make that step? Because I think that's one of the hardest things for people is actually to find someone that is able to sort of be the advocate, I guess, be the GP they need.
Yeah, I would approach Whole NZ. I think you'll find that Whole NZ, which is going to become the place you go for diabetes or up-to-date modern diabetes management, and I see it becoming a big, the place that people would go. I imagine, not quite yet, but I imagine we will have lists of health coaches and doctors and nurse practitioners, nutritionists, dietitians who support this view of metabolic health. And I think we will see Whole NZ influencing the guidelines and perhaps being that voice that is big enough and strong enough to talk to government on these issues. So that's where I think I would be looking.
That is awesome, Glen. Thank you. And where can people connect with you?
Shall
we not even? Don't even?
No, I always feel a little bit uncomfortable. I really want to be talking about the topic of metabolic health, and I don't want it ever to seem like it's selling something, because I'm really not wanting to, and I'm not particularly special in this area. You would get the same or better information if you went and saw Mikki or a low-carb dietitian or a health coach. Maybe I've got the advantage of being able to order the lab tests easily and write the prescriptions when people also need prescriptions. But I'm not the reservoir of knowledge about low carb. I'm just one of the people who are talking about it.
And I mean, I guess at the very least, people could just stop drinking fizzy, right? I mean, really. Yeah. Glen, thank you. This has been a fabulous conversation. I've really enjoyed chatting to you. Thank you so much for your time.
Welcome. Thank you.
Alrighty, hopefully you enjoyed that as much as I enjoyed doing it. Really, really loved chatting to Glen and appreciated the time that he took, and you could just hear his passion in his voice. I feel so privileged to have the opportunity to speak to people like Glen, who really is making some profound differences out at that community level. And if there are general practitioners listening, or you have friends who are GPs who are just might be on the fence or actually just don't know enough, I highly recommend that you get them to check out this podcast, and then they can take it into their own hands. This is life-changing stuff. All right, team, next week on the podcast, I bring to you the conversation I had with Dr. Spencer Nadolski, who is an obesity specialist medicine. It's a bit of a turn on this conversation that I've just had. Again, great information in that potty as well. Until then, though, you can catch me over on Instagram, Threads and X at Mikki Williden, Facebook at Mikki Williden Nutrition, or head to my website, mikiwilliden.com. And why not sign up for my recipe portal? For $12 a month, it could literally change your life. How's that? All right, team, you have the best week. See you later.